Alaikum and good evening, my dear colleagues everywhere. I would like to welcome today all our speakers, really an eminent speakers. I'm proud to have this eminent speaker within us today. And we will have, as usual, these days, there is a new way of delivering this webinar Zoom that we are talking about only one topic. And we are having a very expert people to discuss this topic so that we can have more discussions and we can find all the points, and we have tips and tricks if there is a surgical or non-surgical in this topic that we are going to present. And if you allow me, first I would like to introduce my dear friend, Dr. Mandip Lamba. He is a vitreoretinal surgeon in Dubai Hospital, DHA. And Mandip, he is going to talk about the role of vitrectomy for non-tractional diabetic macular edema. Mandip, the mic with you, please.
Can you see this and hear me, Dr. Amri?
Yes, please. Yeah. You can go ahead. Thank you.
All right. So from the onset, I would like to thank Dr. Amri and his team for giving us this platform to discuss our experiences and, discuss different thought processes across the world. I would also like to thank the team Bayer for giving us this platform again and providing the forum to come back and have these attendees and the forum with us today. So my topic is a little controversial. I mean, before I go ahead with it, I would just like to show a very simple and straightforward case, which we treated 2 or 3 years back. This is a bread and butter case for any medical retina specialist. So this was a patient who presented to us in 2017, and we treated her for over 18 months. Right eye was quite stable, but left eye kept worsening despite of the treatment with serial anti-VEGFs, and we were using Lucentis at this point of time because our pharmacy did not have Eylea available for quite some time, despite of the fact that it was available in UAE at that point. So if you look at the progression from the first OCT to the last, you can see that despite of adequate treatment, this patient actually kept worsening over a period of 18 months. She received 7 Lucentis and 2 Avastans. So this was a time when we got Eylea available with us, and we were well aware of the efficacy of Eylea. We knew that protocol tiers already shown us that this drug was more potent as compared to other peers in terms of gaining visual acuity letters at the end of 2 years, especially for the eyes which were worse 250 or worse to begin with. It had also shown us that aflibercept had actually been a better drug in terms of drying macula. All this translated into good quality of life for the patients who were treated with it. The real world studies recently also showed us the efficacy of Eylea in comparison with other molecules with fewer injections as compared to the study settings. 2016, EURETINA published its guidelines, and it very clearly said that anti-VEGF is the first line of management when it comes to treatment of non-tractional diabetic macular edemas. And in the eyes worse than 69 letters to begin with, aflibercept was a drug of choice. So this patient received 2 doses of aflibercept, and we were able to flatten the macula. We did a bit of laser around some of the leaking blood vessels, and this patient maintained this kind of macular integrity for almost next 18 months. Not every case is that rosy. When you look into the progression of this particular patient in the right eye, this patient was again treated for over 2 years with Lucentis. This was treated by my colleague, and the hallmark was that this patient would come back with diabetic macular edema once you discontinue the treatment for over 2 to 3 months. So this was 3 times that he had already had a recurrence. 4th time when he developed the recurrence, the patient was referred to us. And obviously we had Eylea as a new tool at that point of time. I gave single shot of Eylea. Now what you see here is in response to Eylea, this patient had a fleeting kind of macular edema. So this is where the topography of the DME actually changes in response to anti-VEGF agent, which shows that there is a possibly another mechanism, not only an angiogenic mechanism, but probably a tractional mechanism also at play. When you look at this eye ophthalmoscopically, you'll see a sheen on the top of the macula, despite the fact that it did not have any posterior halide or epiretinal membrane. Look at the OCT closer, you will see a sub-ILM cleft or sub-ILM cyst, which is again a sign that there is some kind of gliotic activity happening at a posterior cortical or ILM level. So we decided to go ahead and do a vitrectomy with ILM peeling for this patient. Immediately following the vitrectomy, the macular edema actually worsened. 4 months later, I injected a single shot of Eylea for this patient, and this was the response. The patient maintained this integrity, dry macula for up till now. It is, I guess, 18 months post-op. Although visual acuity did not improve, but we were able to achieve a good anatomical results. When you look into the EURETINA guidelines, it says that obviously the treatment of tractional DME is vitrectomy. When it comes to non-tractional DME, the role of vitrectomy is controversial. The purpose of this topic is to define this controversial, where this comment in terms of controversial treatment came from, and if we can, initiate a discussion to find a way to merge different kinds of treatment techniques and incorporate early vitrectomy into the treatment regimes that we follow today. So I reviewed all the articles that have been published till date, right from 1992. 1992 was the first article published by Lewis et al. This was for tractional diabetic macular edema detected ophthalmoscopically, where he showed beneficial effects in 10 eyes. Now, let me tell you one thing, that we can divide these treatments into different eras. We're talking about 1990s. This was a pre-OCT era. So the only method of diagnosis was available at that point of time was ophthalmoscopy and fundus angiography. The method of treatment was available was laser and vitrectomies. So this was an era of early vitrectomies. The clinicians would do a laser. If it doesn't respond, they will go back to vitrectomy much earlier. So in 2000, by the year 2000, we had more articles coming on this particular topic, which showed us that complete and durable resolution of DME is possible in the eyes without detectable tractions. Some of the articles during the same era also showed us that completely dry macula can be achieved in 50 to 98% of the patients, with visual acuity gain in up to 47 to 92% of the patients. There was one-off article by Krolpe et al. Which actually emphasized the need of vitrectomy in patients who had vitropapillary traction, because he showed 83% favorable outcomes in the 17 eyes he operated. There was also a theory doing rounds in that era, a theory of extrafoveal traction. I mean, we're talking about traction through anomalous PVD. We're not talking about fibrovascular traction here. So this extrafoveal tractions would actually create a focal retinal imperfusion. This imperfusion would eventually percolate up to the distance of 2 disc diameters and mostly would involve macula. You'll have a ring of microorganisms, leaking microorganisms, which eventually lead to diabetic macular edema. And this would cause recalcitrant or recurrent diabetic macular edemas. The good part was, if you relieve this traction, both the perfusions of both the area of focal traction as well as macula was shown to improve. Later came the next decade, which was an era of time domain OCT. Here, the clinicians were actually having this new tool called time domain OCT, which gave them the measurement of central foveal thickness. But this was not able to define the health of different layers of the retina, inner retinal layers or outer retinal layers as such. Also, they were equipped with the new tool called anti-VEGF. There were a lot of studies which were tumbling, which said that anti-VEGF is a miraculous drug, miraculous molecule, and we also believe in it. No contradictions on that front. But these studies, if you review, Landers did some work on 115 eyes which did not have any vitreoretinal interface abnormalities, but had intractable DMEs, and saw that vitrectomies can improve the CMT in 90% of the eyes, but proved that visual acuity did not improve. It was the work in the same era which was reviewed by EURETINA group, which said that although improvement in the CMT was seen, and gain in the visual acuity was seen in 50% of the patients, but there was inconsistency in visual acuity outcomes. And this became the basis of their comment that the role of vitrectomy in non-tractional DMEs is controversial. They also said that using time domain OCT in retrospect was inadequate. Current era is spectral domain OCT, and this was a wonderful review article published last month, which actually analyzed 8 different studies mentioning 450 eyes which underwent vitrectomy for non-tractional DMEs. The first 6 studies actually are operated on eyes which have already been treated. These were delayed vitrectomies, whereas studies 7 and 8 were operated on naive eyes. So the first 6 studies actually showed significant improvement in visual acuity and CMT. The best part was that these studies actually outlined certain potential biomarkers which would help us to understand which eyes could actually benefit from early vitrectomy and which are the eyes which we should just pursue with serial anti-VEGFs. 2 of the studies which were treated, they studied the treatment of naive eyes, actually reached a surgical outcome of completely dry macula in 193% of the eyes respectively. So using vitrectomy in the naive eyes is a very old concept. It has been tried forever. In pre-OCT era, Lahire et al. Actually mentioned that 77% of the eyes could attain a normal, a normal macula as compared to 15% of the eyes which were treated with laser treatment. In time domain OCT era, Yanali et al. Showed us that 92% of maculas could be made dry by using vitrectomy as a tool. And the same study, 50% of the eyes actually showed more than 2 lines improvement in BCVA. Recent studies, Iglaki et al. Mentioned, and quote unquote, that for every day you delay the vitrectomy in the naive eyes, the chances of gaining more than 5 letters at the end of 24 months decreases by 1.8%. Mikuleska et al. Showed us that photoreceptor defects that were detected in 72% of the eyes preoperatively actually improved to 25% postoperatively at the end of 1 year. So vitrectomies do not only flatten macula, it also helps to regenerate the outer layers of the retina. Some of the other studies showed us that the best results of vitrectomy surgery can be appreciated only at the end of 12 months. Whereas 20% of the CMT actually improves in first week, rest of the 80% takes anywhere up to 6 months to 1 year. So while we had all this data backing us, we in the time of 2015 or 16 probably were not able to figure out which are the biomarkers and which are the eyes which are going to respond to vitrectomy and which ones won't respond to vitrectomy. The recent articles have actually told us certain clinical indicators. I'll just take you through that. So we know that whenever we are going to operate any patient with vitrectomy, we look at the clinical profile and systemic profile of the patient. Good glycemic control, good hypertension control, pronounced good outcomes. 2 of the important factors which were delineated were difference between the time of DME diagnosis and surgical treatment. The lesser the time, the better the result. If there is presence of PVD, pronounces better results. They also emphasize that you should look into the response to the previous treatment modalities. So if a grid laser treatment is done, it pronounced poor visual prognosis. If this was a recurrent DME and had shown good results to previous anti-VEGF therapies, it pronounced better results at the end of the surgery. A lot of emphasis was also paid on vitreoretinal interface because we know it is rich in pro-angiogenic factors like VEGF and cytokines. We also know that it is the posterior cortex which becomes a seat for transdifferentiation into contractile elements which can actually create tangential vitreomacular traction. Sometimes it becomes necessary to remove them early by doing pars-plana vitrectomy, and I presume this is what was present in our patient which we discussed before. A lot of emphasis was also paid on a 3D image construction, analysis, and detection. This is one of the very important things, and I see in my clinic, most of us actually do a mistake of interpreting the DME on the basis of raster scans, which is inadequate. So if you look at this particular OCT, which has DME with PVD, when you look into a 3D analysis, you would actually find that it's a partial PVD with anomalous macular attachment. So this is probably a good candidate for surgery for diabetic macular edemas. So this 3D analysis would also tell you what kind of PVD this patient has, partial PVD, and whether he has any extrafoveal tractions or vitropapillary traction, which has also previously been shown to impact diabetic macular edemas. Role of vitroschisis has always been emphasized. So if you look into this particular OCT, this has an epiretinal membrane and it translates into a vitroschitic fork. Now, thankfully, this patient has got posterior pole disease, but this vitroschitic fork can be as anterior as up to the arcades. So unless you do a 3D construction, you will never be knowing what exactly is the pathology. You might be having a broad-based attachment and might be having a diffuse traction onto the macula. We would presume that this is a benign non-tractional epiretinal membrane and might be mistreating this patient. Some of the recent studies with swept source of OCT have described terms like retinal adhesions and PECs. One of our patients, which was treated for diabetic macular edema and non-tractional epiretinal membrane, shown on the left-hand side, when we did a OCT for 3D analysis for him, we found out that this patient has got a partial PVD with anomalous retinal attachment, along with vitropapillary traction. So we are keeping this patient under watch, and probably this is the right candidate to go in for pars plana vitrectomy. Another case, which was successfully managed with serial anti-VEGFs. So this patient has treated diabetic macular edema. He had a extrafoveal macular traction. But when you look into this 3D image construction, you will see that this patient has got a vitropapillary traction and multilayer vitroschisis. So we are keeping this patient under observation. In case she comes back with recurrent macular edema, probably we might be considering a surgical approach for her. Looking into the physiological biomarkers, external limiting membrane is a strong, interrupted external limiting membrane is the strongest indicator for poor visual outcome. Similarly, ellipsoid zone has also been described as a prognostic indicator. If it is interrupted, it pronounces poor prognostic factor. Some emphasis has been paid on the distance between ELM and EZ and ELM and RP. So normally, the distance between external limiting membrane and ellipsoid zone should be less than ellipsoid zone and RP. But we find that this distance is inverse. That might show that there is an early insult at the outer segment of photoreceptors, and these patients might warrant a earlier treatment, more aggressive treatment, if not with VEGF, probably with vitrectomies. We know that we have to always study the macular perfusions in these patients, either with OCTA or with FFA. Drill is again a poor prognostic sign, simply because we know that drill is actually always associated with low capillary, superficial and deep capillary counts, as shown in the second row in comparison with the top row, which is a control. So we do have some more weapons in our hand. We know that how do we differentiate diabetic macular edemas now, which ones are going to benefit with vitrectomy and which ones might not. But the thing is, we still tend to go ahead with anti-VEGF injections, go on and on with it. Why do we do that? Probably because we are scared that vitrectomy is a surgery, and we believe the anti-VEGFs are more, let's say, less interventive procedures and more safer. But if you look at the risk factors of both the modalities of treatment, if you consider that you are giving 8 to 9 injections a year, the cumulative risk factor of endophthalmitis is close to 1 to 1.5%, while the vision-threatening complication, that is retinal detachment in vitrectomy, is again 1 to 1.5%. So they are similar. At the same time, the cost of vitrectomy is almost 1/3 as compared to serial anti-VEGF therapy. And of course, when you talk of Corona times, when you do a surgical approach, we know that we can significantly reduce the number of visits of the patient in the clinic as compared to serial anti-VEGF therapies.
If you allow me, Mandip, you
recent studies, macular studies rather with small gauge, have shown 0% complications. Some of the studies, not all. This was an interesting observation by Morris, Landers et al., where they studied 181 eyes which were treated for non-tractional diabetic macular edemas in 37 different studies. They looked for the complications which happen in these eyes. One of the concerns was presence of retinal breaks, but they said the retinal break had no impact on final visual acuity. Retinal detachments were present in 0.7% of the eyes, but these also included vitrectomies which were older, in 90s and 2000s.
Yeah, Mandeep,
epiretinal recurrences were mentioned at 36% in non-ILM
can you hear
eyes.
us, Mandeep?
There are isolated reports of vitreous hemorrhages and endophthalmitis, and there was no mention of macular hole formation.
Oh, his earphone came out from his...
So what is the rationale finally? Why do we
Mandeep,
do a
can you hear
vitrectomy
us,
for
please?
these DMEs? Because we know from 1980s, Dukes told us that vitrectomy thins out retina. We know that it improves the diffusion of oxygen many folds into the vitreous cavity. We know that posterior vitreous detachment are preventive to the people who have PVDs are less likely to have diabetic macular edemas. And the patients who develop spontaneous PVDs actually show resolution of diabetic macular edemas. We also know the role of ILM peeling, or rather I should say that complete removal of posterior cortex. It improves the diffusion of oxygen into the retina. It also improves the VEGF removal from the retina. It also reduces the post-operative ERM formation, increases microcirculation, and reduces leakage. So I would just share
Mandeep, can you hear me,
short experience of ours.
Dr. Mandeep.
We always very religiously believed in retina guidelines, and we were always treating non-fractional diabetic macular edemas with serial anti-VEGFs with Eylea as first line of management, as we discussed. But during this time, we had a lot of patients who were sent to us who had insurance lapses, loss of jobs, and sometimes we had insurances who were covering patients for surgical interventions, but not covering for anti-VEGF therapies. So monitoring, for monetary reasons, we started treating these patients. It's a small retrospective experience of 6 eyes with 5 patients where we did PPV with ILM. 3 eyes were naive,
Dr.
one was
Mandeep?
recurrent, 2 recalcitrant. When you look into this outcomes, the flat macula was achieved at the end of 8 months in all the 6 patients. Visual acuity improvement was seen in naive eyes, but not seen in, older treated eyes. But visual acuity was stable in them. We did not have any complication in any of our eyes. So when I was trying, this is my last slide, I was trying to actually conclude this presentation, have one more slide to conclude it, but I deleted it because I was really not sure how to conclude this topic. And it is just an attempt to initiate the discussion. There are a lot of questions which go unanswered because we are in urgent need of a Hello, can you hear me?
Sorry that we need to stop Dr. Mandeep and to mute him because he is not hearing us. Mandeep, you exceed by more than 10 minutes. We are trying to contact you, but you are not listening to us. So we are sorry, we need to stop. So can we now start? Yeah, the second talks, it will be by my dear friend, Dr. Tariq Siddiqui, and Tariq Siddiqui is a consultant ophthalmologist with medical retina subspecialty in Rashid Center for Diabetes and Research in Ajman. And Dr. Tariq, he is going to talk about the role of Eylea in neovascular AMD, Q12 and beyond. Dr. Tariq, please, you have the mic with you.
Good evening, everybody. Can you hear me?
Yeah, we can hear you, please. Yes.
Okay, good evening, everybody. Thank you, Dr. Amri Bayer, for inviting me to speak about Eylea in the management of neovascular age-related macular degenerations, Q12 and beyond. As we all know, that aflibercept is a recombinant fusion protein, and it has a multi-target mechanism of action. Aflibercept has a strong binding affinity and extended durability, and that makes the only anti-VEGF to bind for both vascular endothelial growth factor and platelet growth factor. Both of them, they play a key role in the pathogenesis of different retinal diseases, mainly neovascular AMD. And this binding affinity, strong binding affinity and extending durability makes aflibercept the ideal treatment option for a proactive treatment with extended intervals. Aflibercept binding affinity here is really equal to 100 times of ranibizumab, and this means that aflibercept is better suited for the use in extending treatment intervals. Both the binding affinity and half-time of aflibercept contribute to the longer duration of action. The pharmacokinetic profile of aflibercept in the aqueous humor in patients with neovascular AMD demonstrate that aflibercept has a longer duration of VEGF suppression than ranibizumab. As you can see here, the duration of VEGF suppression up to 71 days. In a small study, in a group of patients who had ranibizumab loading dose of 3, then followed by PRN regimen, 7 of these patients, they had a persisting activity of neovascular AMD after 2 years. These were switched to aflibercept PRN regimen and followed for another 15 months. The aqueous humor samples for the VEGF suppression was the double of ranibizumab. So the question here, which comes to us, does these molecular characteristics of aflibercept impact the clinical outcomes in patients with neovascular AMD? Historically, we can go back to view 1 and 2, when aflibercept achieved a robust vision gains after the loading dose that were maintained by year 2, with 48% of the patient extended to interval of 12 weeks. And this study has shown that bi-monthly dosing with aflibercept delivered equivalent efficacy to monthly ranibizumab. So it did show a non-inferiority of aflibercept compared with ranibizumab in a proportion of patient maintaining vision. And according to the guidelines between 2012 and 2017, as you can see here, this is the example of the treat and extend in Manchester Royal Eye Hospital. We were able to extend up to 12 weeks in year 2 until ALTAIR has been published, 52 weeks result in 2018, and 96 weeks was published last year. And the goal of this study was to find a proactive, flexible treatment and extend regimen to reduce the treatment burden while maintaining a patient visual acuity gains. This flexible approach avoids both overtreatment and undertreatment while optimizing the function and anatomic outcomes in the retina. There were a total of 246 patients with exudative AMD treated over 96 weeks, and they were all treatment naive, subfoveal neovascular membrane. 36% of these CMV were classified as PCV. As you know, the study was carried in a Japanese population. The primary objective was the efficacy of aflibercept with 2 types of regimen. Secondary object was the safety of aflibercept. And technically, the patient, as you can see here, received aflibercept treatment once a month for 3 months, followed by injection at 16 weeks. At 16 weeks, randomization happened. 1-to-1 into 2 groups. Treatment and extend dosing regimen was either a 2 weeks interval adjustment or 4 weeks interval adjustment. And when you extend, maintain, or shorten the interval, you extend in a patient with no fluid, you maintain if there is resisting fluid but decreasing, you shorten if there's new fluid, persisting fluid, change in the visual acuity, or new macular hemorrhage. Interestingly, the intervals between intravitreal injections of aflibercept after 16-week randomization couldn't be shorter than 8 weeks or longer than 16 weeks. So, as you can see in this slide, the investigators assessed visual acuity at 52 weeks and 96 weeks. Patients in the 2 groups showed significant vision improvement, 9 and 8.4 respectively at 52 weeks, and 7.6 letters and 6.1 letters respectively at 96 weeks. We have to mention that both groups showed a significant reduction of central retinal thickness, which was maintained throughout the end of the study up to 96 weeks. If you go back and see mean number of injections, both groups shows 10.4 mean number of injections over 2 years, and notably in year 2, they had fewer than 4 injections of aflibercept. Again, notably here, by the end of the study, up to 60% of the patients were maintained at intervals of 12 weeks or beyond. As you can see here, 12 weeks, 14 weeks, 16 weeks, and this comprised 60% of the total population of the study patients. Again, by the end of the study at 96 weeks, more than 40% of patients were maintained at the maximum treatment intervals of 16 weeks. This wasn't achieved before in view 1 or view 2. That's the message, actually, a take-home message from this study. If you go again and talk about the safety of or adverse events of this study, it did show that it's consistent with the known safety profile for aflibercept. As we can see, intraocular inflammation, endophthalmitis rates, and vasculitis is still very, very low. So to sum up this study, aflibercept was specifically designed for a high affinity binding to both VEGF and related growth factor. The pharmacokinetics profile in the aqueous humor of patients with neovascular AMD supports the assumption that aflibercept has a longer duration of VEGF suppression than ranibizumab. Pharmacokinetic simulation of vitreous drug concentration predicts that 2 mg aflibercept has a longer duration of VEGF suppression than 6 mg brolucizumab. The extended duration of VEGF-A suppression with aflibercept supports the extension treatment intervals in patients with MyoMD. As we mentioned already, in ALTAIR, up to 60% of the patients were maintained at intervals of 12 weeks or more, and more than 40% of them were maintained at intervals of 16 weeks by end of the study. And as you can see here, this treatment and treatment extend regimen has helped physicians to adopt it in the era of corona pandemic, as we all know that minimizing the potentially life-threatening risk of COVID infection outweigh the risk of recurrence of this disease and visual loss. So we need to have such a regimen to reduce the chance of contracting this disease, which increased by increasing visits of patients, especially most of the MVD of the neovascular AMD patients are elderly people. And thank you.
Thank you very much, Dr. Tariq, for your presentation, and thanks also for Dr. Mandeep. We'll give only 2 or 3 minutes for discussions. If there is any question to Dr. Tariq from panelists or from Dr. Nazim.
No, wonderful talk. I think even the real life data, which has been published, has also had a similar outcome, because now the treat and extend protocol seems to work pretty well, even after 24 months or more. And I think that's the way to go now. It has been shown in both the study of the real life data from Switzerland as well as from Slovenia has shown similar data even for 2 different scenarios of 2 different countries. So yeah, in the first year, you may have around 8 injections. In the second year, you may have a 4 to 5 injections when treat and extend. Yeah, the most important point, I think, in treat and extend protocol, that you follow the patients, you treat the patient monthly until it's dry, then you start to extend as you like, as most of us extends every 2 weeks. And then if there is a recurrence, you reduce the extension interval and then go back behind and again extend. I think that works well both for the patients and the outcome. Yeah, I think that's the way to go now. From all the studies, even the meta-analysis has also shown similar. Yeah, wonderful.
Any comment, Dr. Ramzi, if you have anything to say? Yeah, please, Dr. Ramzi. Just unmute yourself, Dr. Ramzi. You are still muted.
Thank you, Dr. Tariq. This is a very good talk. So, as Nazim mentioned, this is our daily practice right now in corona pandemic duration. We try to reduce the number of visits and also keep the patient visions as much as possible. And therefore, this is treat and extend regimen that you mentioned. It's almost same that you apply in my daily practice. And I think this is really the best way in today's in this pandemic regime. It's really good. I agree with you. Thank you.
Yeah, this study really made the difference, because as you mentioned, between 2012 and 2017, we used to go maximally to 12 weeks. But this study has enabled us to go further to 16 weeks, up to 16 weeks, which is literally 4 months. So
Yeah,
that's
this is
really Yeah.
Yeah. This is only the 16 weeks extension is not that I'm doing. This, the maximum is 12 weeks.
Yeah.
So, but you mentioned about 40% of patients maintain
Exactly.
during this 16 weeks. This is new information. This is really interesting.
Yeah,
Maybe
exactly.
we should try in some patients and to extend like 16 weeks more than 12 weeks.
Especially in the era of coronavirus. I mean, you want to really reduce the number of visits per year, you know.
Yeah.
Dr. Tariq, can you just stop sharing? So can you stop sharing?
Sorry,
and we could.
sorry.
Yeah, I think the data also has shown that 40% of the patient may benefit from 16 weeks extension, whereas the 60% or more benefit from 12 weeks or more. So there will be a subset of patients which may respond differently. And those kinds of patients, you cannot have the same cohort because the environment, how the trial is done is so controlled. And we, in real life, we have an uncontrolled environment in terms of glycemic control, in terms of visits. So probably, yes, there will be some subset of patients which may benefit from 16 weeks in extension without any recurrence. Yeah, so our mind has to be open to take this knowledge into our practice.
Yeah, as you can see, Nazim, here, this patient's population, there's 36 patients, they have a BCV, you know, as you mentioned. So it can be different from country to country, you know.
Yeah,
so the idea might change.
Yeah, the concept is important to apply to our practice.
Exactly.
Yeah.
Thank you very much for all of you. I think we will need to move to the second part of our meeting. The first part already done with Dr. Mandeep and Dr. Tariq. Now I would like to introduce Dr. Ayman Midanat. Dr. Ayman Midanat is a senior consultant, ophthalmologist, and retina specialist, and he is the general manager of Ammon Eye Center in Jordan. And Dr. Ayman, he is going to talk about macular hole and retinal detachment in high myopia, challenging and techniques. And before he starts, just if you allow me, I would like to also to introduce our panelists for this session, especially Dr. Carlos Matthew. Is an MD, consultant, and founder of vitreoretinal surgery at IMO, associate professor of fellowship program at IMO Institute of Microsurgery, Ocular, Barcelona, Spain. And I would like also to introduce my dear friends, also Dr. Ramzi Abshi is an MD professor in ophthalmology, chairman and director of founder of Borsa Retina Eye Hospital in Turkey. And finally, and not the last, is my dear and close friend, also Dr. Nazim Al-Hussein, a vitreoretinal specialist in Mediclinic, Parkview, Dubai, UAE. And I would like to ask Dr. Ayman to start his talk, please.
Thank you, Dr. Muhammad, for the nice invitation. I know that you've chosen a difficult topic to talk about today, but it's really interesting, and I'm really honored that I have my dear colleagues, Dr. Ramzi, Dr. Carlos Mateo, Dr. Nazim Al-Hussein, and Dr. Tariq with me. So we'll have definitely an excellent discussion. Myopic macular hole is a common complication of pathologic myopic eyes with axial length more than 26.5 millimeter or a refraction more than -6 associated with degenerative changes in the sclera, choroid, and the retina. Some they say it's -8, but -6 is fine. Prevalence of 8.4 has been reported with a greater affinity among the Asians compared to Caucasian or Black individuals. I think we in the Middle East have probably a little bit higher incidence than the Caucasian, but less than definitely the Asian population. OCT played an important role to precisely define the ultrastructural characteristics of myopic macular hole. According to Kono et al., there are two types of myopic macular hole. The flat one, the flat myopic hole, which is caused mainly by vitreoretinal traction and inner retinal degeneration. Usually it's not associated with RD, it's like the idiopathic macular hole. And the other type is the myopic traction maculopathy, which might be associated with lamellar, full thickness macular hole, or retinal detachment. Myopic traction maculopathy is a single pathology with different stages. This is what Barbara Parolini et al. Proposed with their new scheme of staging of myopic traction maculopathy. In fact, Parolini et al., Barbara and her team, they divided the myopic traction maculopathy into more than one stage. Stage one is inner outer macular schisis, and then stage 1B is with lamellar hole, stage 1C is with full thickness hole. In this case, we observe, in this case, we do PBV, and in this case, we do PBV also. The stage 2 is definitely predominantly macular schisis with outer macular schisis. Stage 2B with lamellar hole, stage 3 or stage 2C with full thickness hole. In cases of only outer macular schisis, we observe. In cases of lamellar hole, we do macular buckling with late PPV. And in case of full thickness macular hole, we'll do macular buckling with pars plana vitrectomy. Stage 3 is macular schisis detachment with macular detachment. In this case, we do macular buckling only. And if it's associated with lamellar hole, we add PPV. And in cases of full thickness macular hole and macular detachment, we do macular buckling and PPV. The fourth stage is macular detachment. Either we do macular buckling with PPV if it's symptomatic, or macular buckling with PPV if it's associated with full thickness macular hole. Definitely, we can add a plus if there's an epiretinal membrane or if there's an associated foveal schisis. This photo was in the Mediterranean Retina meeting, the 8th meeting in Dubrovnik, where Barbara, in fact, she presented this staging for the first time. And this is our dear friend, Dr. Sungul Ozdik. What about the pathogenesis of myopic tractional maculopathy? Myopic traction maculopathy was described to be caused by two factors mainly. Pre-retinal factors, which are forces causing centrifugal and tangential traction to the retina, as in PVD, vitreomacular traction, or epiretinal membrane, and posterior precortical vitreous pockets. The subretinal forces, which include forces that cause centrifugal traction on the retina as deformation of the sclera, as in cases of posterior staphyloma. Now, both factors can damage the retina if they overcome the elasticity, which is limited by the thickened vitreous remnants on the retina, the rigid and thickened ILM, stiffness of retinal arterioles, and degenerative retinal changes, which is the atrophy of retinal pigment epithelium and the choroid. Management. Although pars plana vitrectomy with posterior hyaloid removal, ILM peeling, long-acting gas tamponade, and face-down position is still the gold standard for the successful closure of idiopathic macular holes, the treatment of myopic macular holes remains a challenge, a real challenge. As the closure rate of myopic macular holes is less than idiopathic macular holes in the range of 65%, in some cases up to 100, but mainly in between, several techniques have been adopted to improve surgical outcome. Vitrectomy in high myopia, what are the challenges? Number one, the axial length. Due to the increased axial length and posterior staphyloma, standard instruments may be too short and therefore unable to reach the posterior pool, and it happens. In order to reach the posterior pool, added pressure on the sclera with the instruments will cause distortion of the cornea with the resultant distorted image. And in some cases, definitely you might have a touch between the cornea and your viewing system, wide field viewing system, which add to distorted image. So ultrasound to measure the axial and identify the posterior staphyloma should be done preoperatively. And the distance between the sclerotomies should be increased to avoid verticalization of the instruments and restore an adequate working angle for your instruments, of course. The 20 gauge instruments can be used as they are longer enough. They are longer than the 23 and 25 and 27 instruments. I can be longer enough to reach the posterior pole. Even if you start with your trocars, you can remove the temporal trocar, you can enlarge and then use the 20 gauge instrument. Alternatively, the trocars can be removed during the surgery in 23, 25, and 27 gauge techniques to gain extra millimeters. Recently, dedicated instruments has been developed to deal with longer eyes. Visualization and removal of epiretinal membrane and ILM are more difficult in high myopic eyes due to thin and atrophic retina, friable and sticky tissue, low contrast due to atrophy of retinal pigment epithelium and choroid, longer axial length. All these factors can lead to incomplete removal of epiretinal membrane, fragmentation of the ILM and iatrogenic macular holes. Staining of the vitreous with triamcinolone stenoid is very important since many cases of apparent complete posterior vitreous detachment have vitreous cortex still attached to the retina, especially in foveal cases and macular hole. This should be removed completely with any epiretinal membrane. Since myopic ILM is firmly adherent, friable and sticky, multiple staining are advisable to be sure of its complete peeling. Peeling initiation of ILM is the most dangerous step in myopic eyes, in highly myopic eyes. It's advisable to initiate the peeling at least 1 disc diameter to the temporal to the fovea. Myself, I do initiate a temporal flap using a Finiciflex loop after dyeing the ILM with brilliant blue G-dye. Since myopic ILM and retinal tissue are more fragile, a bubble of perfluorocarbon liquid placed on the macular area will stabilize the retina, especially in the presence of retinal detachment. Many studies have demonstrated that myopic macular hole have a worse closure rate than idiopathic macular hole, as highly myopic eyes has a shortened retina over an elongated sclera, often with posterior staphyloma. In order to compensate for such retinal shortening, I use an inverted ILM flap, a C-shaped flap to cover the hole. Myopic retinal detachment. High myopic eyes have tenfold risks of developing retinal detachment, and almost 55% of non-traumatic retinal detachment occur in myopic eyes. Besides peripheral retinal lesions, RD in myopic eyes can arise from paravascular tears, holes, and macular holes. Although PPV nowadays gain more popularity in treating myopic RD, but still the buckling procedure, if used, is not without risks in these cases. High-risk surgical complications associated with buckling in these cases include muscle avulsion, vortex vein damage, hemorrhage, subretinal fluid retention, and globe perforation. Development of cataract with PPV is a major concern in myopic RD, as the patients are usually significantly younger than those with idiopathic RD. Although the incidence of cataract in younger patients after vitrectomy is much less than older patients, but still a risk. Keeping the lens clear in these cases is very important because of the problems of unilateral pseudo-phakic young patients and the risk of post-op hypotony unless there is existing lens opacity. In case of clear lens, several surgical expedients may be used to avoid lens damage during peripheral vitrectomy. The use of non-contact wide field viewing system to improve visualization of the periphery is important. Peripheral indentation may further aid the visualization of retinal periphery, and the trocar cannula should be inserted 4 mm from the limbus to allow better range of accessibility to the periphery. Switching hands of the vitreous cutter without crossing the instruments behind the lens is very important. If you go and fro behind the lens during your vitrectomy, there's a high chance to develop cataract. The use of valved trocars and keeping a moderate pressure inside the eye with low turbulence is also advised. Scleral buckle to buckle the macula, or in case of PVR, associated myopic artery. Although endolaser application for retinal lesions in high myopic eyes is not usually needed in myopic macular hole RD unless there is a associated peripheral retinal lesions, it is still a problem due to atrophy of retinal pigment epithelium and choroid. Alternatively, a mild cryotherapy can be used for peripheral lesions. Sclerotomy leakage of definitely one of the advantages of minimally invasive vitreoretinal surgery is to do transconjunctival sutureless vitrectomy. Although shorter operative time, faster post-operative period, recovery, less inflammation, less patient discomfort than traditional vitrectomy, but still self-sealing sclerotomies not always remain tight, especially in high myopic eyes, possibly due to myopic thin sclera, deranged scleral fibril structures, vitreous plugging is less efficient in high myopic eyes due to liquefaction, and finally, the pressure exerted on sclerotomy by the surgeon may undermine. To avoid leakage, which is usually lead to hypotony in early post-operative period, its complication, the following precautions may be considered. Trocar insertion technique is very important, really important in these cases, as it has been demonstrated that long biplane oblique perpendicular tunnel have a lower incidence to leak. In order to do that, it's preferable to puncture the sclera at a narrow angle using a trocar plate with bevel down position that is parallel to the limbus. This will cause a longer tunnel. A single transconjunctival transscleral absorbable suture, if needed, is effective to stop the leakage. The tamponade, gas tamponade is better than silicone oil. I hate silicone oil, except in some cases. So the gas tamponade is better than silicone oil in cases of PV for myopic RD because of the irregular contour of vitreous cavity for the presence of staphyloma and peripheral ectasia, except in cases of myopic macular hole and associated PVR where silicone oil is preferred as longer tamponade is needed in these cases. This is a case of a flat macular hole I've done long ago, just vitrectomy, peeling, and gas, and the hole was closed. This is a case of a myopic macular hole with macular schisis and retinal detachment in 65-year-old lady operated with PPV island peeling, C3F8 gas, tamponade, and we managed to flatten the retina. But let me say that this is the case pre and post-op, and this is her sister. In fact, this is her right eye, and this is the left eye. She had the same problem, and this is the picture of after operation. Sorry, I didn't have a photo for this patient before surgery. In Jordan, we don't have macular buckling, and I've never done macular buckling in my cases. I like definitely to hear the opinion of my dear friends Ramzi and Carlos about that. So in conclusion, myopic macular hole in early stages is often asymptomatic and difficult to identify biomicroscopically. OCT is the best tool to detect minimal macular changes. The recent staging of myopic macular hole by Barbara Parolini et al. Gave us a clear view about the pathology and management of the disease. Management of myopic macular hole and myopic traction maculopathy with or without RD still represent a challenge to retinal surgeons. Many surgical tips and tricks can make the procedure easier with favorable outcomes, so preventing sight-threatening intra and post-operative complications. Thank you.
Thank you very much, Dr. Ayman, for this very interesting and comprehensive and excellent presentation. I think there will be a lot of questions to you and also from your friends here available. Okay, we'll start with Dr. Carlos. If there is any comment first, I need only first a comment, then we can go for discussions.
I have many comments. I might, first of all, congratulations. You have a huge experience in that, and this is wonderful. Let me ask you things. First, what gauge do you use? 23, 25, 27? Because in high myopes, you know, the distance between, as you mentioned, the distance is so large. And then your force, if the eye moves a little bit, your distance moving, then this is the first. The second, about the gauge. The second about the posterior highlight, because I'm the devil. Okay, I'm the devil. I never try to remove the vitreous towards the periphery. I never do it. I use in some cases triamcinolone you mentioned, but you know, remember that you can break the retina, and high myopes have these areas of strong adhesion, and the problem is in the staphyloma. Then I don't try to go to the periphery because the risk to promote a break is so high. I don't do it. I try to solve the posterior problem. And the third thing, I have more, but you know, this is the three first questions. And you haven't shown it, but you know, there are some macro holes. You see it in the OCT that you have this tissue over the macro hole, and in these patients, the problem is that you stain and you don't have staining. And then you go there and you start with your flexible loop. This is a great idea because you see this, you know, tissue yellow that you have to remove it before to remove the ILM. Then, you know, I would like to comment about that. You know, this tissue that is over the retina and prevents good staining. These are my
Thank you very much, Carlos. These are very interesting questions. Number one, I use a 23 gauge vitrectomy in my practice. And regarding to your question about the posterior hyaloid, this is a very important and very interesting question. Peeling or removing the posterior hyaloid in highly myopic eyes is really a very, very difficult task. This is number one. Number two, we have all to know that even if you manage to remove or peel the posterior hyaloid, sometimes it's very difficult to peel it up to the periphery. Mm-hmm. It's really difficult to peel it up to the periphery, especially when the base of the vitreous, as most of cases in myopic eyes, the posterior hyaloid has moved posteriorly, as you know, unlike the normal eye. So sometimes it's really difficult to try, and I advise you not to try to peel the posterior hyaloid up to the periphery. If it's difficult, just leave it and try to remove as much possible of the vitreous you can, because if you are going to go ahead and try to peel it up to the periphery, you'll do more damage than benefit. So this is the second thing is I use multiple staining, because as we know, in cases of myopic detachment, the vitreous has what we call lacunae, or schisis of the vitreous near to the ILM. Sometimes you remove part of the vitreous and there is a remnant vitreous over the retina. So just try to remove this as much as possible, because it will definitely improve your result. Your third question about the presence of epiretinal membrane over the macula, as I told you, I try to remove all the membranes. So I use a trypan blue to try and stain epiretinal membrane, because as you know, the brilliant blue is not the stain to stain the membrane. Stains the ILM very well, but does not stain the epiretinal membrane. So I stain it, and I try to use the Finis Flex Hook loop to initiate an edge and remove it gradually. But definitely I try to remove all the membrane if I can before trying to remove the ILM from the retina. Thank you, Carlos. These were very interesting questions.
I think
thank you, Dr. Ayman. Can we okay, we will come back to you, Dr. Carlos, because I know you are having to give us a lot of idea about your techniques. Also, there is so many things. Sure. You do it by yourself, I know. Let's go to Dr. Okay, Dr. Nadim, you want to ask?
Yeah.
Or Dr. Ramzi?
So I have a very practical question, but I want your opinion. A scenario, you have a total retinal detachment and you have a posterior staphyloma. You have a horseshoe tear on the superior, and there is a macular hole full thickness. Okay. The problem comes, you you put a bubble of PF4, which you will prefer to use, over the macular hole, and you stain the ILM around the PF4. Then you keep on putting the PF4 until the edge of the posterior edge of the horseshoe tear. Okay, now the question comes, once you laser done everything, when you do the fluid air exchange, there is a high chance, if you are not doing properly, this fluid may go into the posterior subphylum. Now, and all the hard work you did to flap over the macular hole will go to waste. So what do you do differently to not to have that?
Yeah, this is also a very, very important question.
Tricky question, Dr. Ayman.
No, it's very important because you face it. Number one, when definitely you want to try and flatten the retina with perfluorocarbon and try to either laser the periphery or do it with a cryo, then you have to do the air fluid exchange. The trick while doing the air fluid exchange is two things. Number one is to use a low pressure, never use a high pressure, and use a passive removal of the fluid rather than an active. I know that all of us were using our cutter to remove or to do the step of air fluid exchange, but in this case, never use it because there is a high chance of complication if you use it. So use a low pressure and use a passive sort of removal of the fluid from inside the macula. If there is, and as I told you, I like to use the gas, the C3F8 or sometimes C2F6 gases in these cases in myopic detachment. I don't like to use the silicone oil. So if there is a remnant of subretinal fluid, I wouldn't worry about that, because with the presence of the gas, it will be removed. But if I'm intended to use the silicone oil, what I do sometimes, I use a 30 gauge silicone tipped cannula to try and remove the subretinal fluid through the hole itself, just trying not to enlarge the hole and not to touch the retinal pigment epithelium. This is what I do.
Okay, Dr. Carlos.
Let me tell you, for me, this situation that you mentioned, for me, is the best one. I'm sorry for that. You know, the thing I do is I do the vitrectomy as Ayman said. Then I put perfluorocarbon liquid to the periphery, and then I stain under perfluorocarbon liquid. You know, the idea is from Cesare Forlini, it's not mine. Amazing. You know, it takes seconds to stain. Then the dye goes over the perfluorocarbon liquid, and then you stain it, and then you remove the excess of dye, and you see it perfect. The retina is stable, the macular hole is closed, and then you put your flap. But as you mentioned, if you have a fluid exchange at the end, you have some fluid down, and here's your ability to stay and to put the flap over the hole. Because of this, I always use superior to inferior flap, because at the end I aspirate down. And then when the patient is seated, then, the flap is maintained the position. But I love it. In some cases, in fact, I do a 12, hole in the far periphery near the ora serrata to remove as much as possible the subretinal fluid that you never remove all the subretinal fluid.
Okay.
Can we have Dr. Ramzi about this one, please?
Let me add one thing before Ramzi started.
Yeah.
When I started doing the macular hole in '95, we were using an autologous serum taken from the patient himself to put over the hole after we do a proper vitrectomy. At that time, we didn't use to peel the ILM. I started to use it again in my myopic macular hole to just keep the flap over the hole itself. I just put, after doing the air fluid exchange, some drops of the autologous serum just to keep the flap not moving after or at the end of the surgery. It's very beneficial.
Okay.
Ramzi.
So thank you, Ayman. This is excellent talk, and you mentioned all the details of macular problem in myopic patients. So let me give my idea about the Dr. Nazimu's case scenario. That is really important, but usually in my practice, I try to use an inverted flap technique in macular hole or macular hole detachment. So that's the problem. When you do fluid air exchange, the fluid comes to bear posterior staphyloma under the retina, and it may remove the ILM flap. And for this, if you use ILM flap, it's the best way, that, as Carlos mentioned, that we try to remove subretinal fluid from the posterior tear as much as possible to dry the subretinal tear. That's the only way. But if you don't use ILM flap, this is easy, as Ayman mentioned, because most of the patient has no RP on the posterior staphyloma, so we can drain subretinal fluid from the whole area. So Ayman, you mentioned about the some tricks to reach the posterior pole in patient with long posterior staphyloma. That's okay, I agree with you. Maybe we can add another one that usually apply, prefer 4.5 millimeters trocar infusion from the limbus. It's the other way, because you at least you can reach 1 millimeters to be able to reach the posterior pole, and that you did not mention that we can do this. And the other important things in my practice, that I use triamcinolone in all cases to visualize posterior cortical vitreous. This is very important. Also, I use finest loop more than ILM peeling than to remove posterior cortical vitreous from the surface of the retina. Yes. I don't, in my practice, I don't use finest loop to create peelable edge in ILM, because it's not easy, because you have to press the retina. I feel that you may traumatize the retina, especially in myopic patient. If there's subretinal fluid, it's very difficult to make a peelable edge with finest loop. Maybe I can would like to learn your trick from in this topic later on. And the other things, so also the visualization of ILM is really, really difficult and very important. And in my practice, in all cases, I use, in all macular case or surgery case, I use non-contact system, IBOS system, but except macular, myopic macular hole or macular surgery, we should use contact system. Otherwise, it's not possible to see the edge of ILM or the ILM visualized. I think Carlos agree with me.
Absolutely.
So, except this case, in my practice, I can manage everything in macular surgery with non-contact system. So this is another important things. Another things, also ILM is really, really fragile in macular hole. It's very strictly attached. It's much difficult to peel ILM when you start to peel comparing to standard case. And therefore, it's very strictly attached. When we start to find a peelable edge, I change my forceps. I use blunt tip forceps, like anti-creeping forceps sometimes, because it's really strictly attached. And when you use sharp ILM forceps continue, it tear, and you start to again and again. And blunt tip needle sometimes helps to continue without tearing the ILM during especially inverted flap technique. And the other one that you mentioned is PFCL. I use in most of the patient during the peel ILM, because it may help with contraction during the peeling of ILM, especially in this case. Thank you.
Thank you, Ramzi. You've raised a very interesting topics. Number one, regarding the finished loop. Yeah, I use it definitely to remove the vitreous from the surface of the retina at the periphery. When I'm trying to do a posterior hyaloid removal, and I cannot take it up to the periphery, the finished tube is very important, and it's very helpful tool just to try and peel the vitreous from the surface of the retina. I totally agree with you. I find that I've tried when I'm peeling my ILM, I don't use anything except an end-gripping end-gripping ILM forceps. But in cases of myopic hole, it's really difficult to use this forceps to peel. You know, it's very thin, it's very sticky, it's very friable. You have to create an edge, and the whole trick is to try and create an edge. And I try to create a good edge so I can just use my end-gripping ILM forceps to peel it properly. Now, the trick in high myopic ILM peeling is to try and create this edge. I tried the diamond dusted scraping ILM, but scraper, but it's so traumatic. And I found that the finished loop is really less traumatic than the diamond dusting scraper. This is one. The other thing is regarding the triamcinolone acetinoid. I definitely agree with you. Without it, it's very difficult to do the vitrectomy and myopic hole vitrectomy. And sometimes I diluted, of course. I diluted 1 to 3. It's easier to use. And I stay more than, as I told you, I stay more than once. And in cases of the presence of iberital membrane, I use the trypan blue, then I use the beryllium blue to stain the ILM. So it's a tricky cases, and definitely you have to use all your weapons and your armamentarium to try and finish the case. Regarding the use of a contact system, yes, definitely I agree, because the macular view is definitely better, and I used to enlarge as much as I can the macular area when I'm trying to start peeling the ILM. I found it's very helpful.
Maybe
Thank
ask
you very
another
much,
question.
Doctor.
Sorry, Mohammed.
Yeah.
So
yes,
in some
Doctor.
patients, it's really difficult to peel the ILM. Even we peel the ILM, if there is no RP on the whole area, on the backside of hole, it's difficult to close the hole and attach. In such case, what's your trick, and what do you do except regular surgery? Also, do you use laser sometimes to attach or to close the hole in especially wide posterior pole cases? What's your trick?
Let me be frank with you. I tried it once. I used very light laser at the edge of the fovea because it was really difficult, and I put silicone oil. But the post-op results regarding visual acuity was not good. I never repeated that. I will never repeat using laser treatment at the edge of the hole. What I will do, if I cannot peel the ILM, I'll do my best just to remove every bit of the vitreous from the surface of the retina, and I'll drain the fluid, and I'll put silicone oil, and I'll keep my fingers crossed.
Actually, I faced a problem in the same scenario where there was extensive chorioretinal atrophy on the posterior pole with the macular hole detached retina. So I lasered the macular hole because at that time we were not doing ILM flapping. That was around 8-9 years before. So, but then I realized later, probably in these cases, only the flap not plugging could be a way out to just close the hole, because the patient came back to me with fluid in the posterior pole again, and I was back to square one. So what I now feel from the discussion, that probably at that time, if we would have known to flap the ILM, then plugging would have saved me.
Thank you, Doctor. I have to take also the opinion of Dr. Mandeep with us. Mandeep, if you have any comments.
There is a question from Mandeep on the...
No, that one we'll keep it later on. I saw that. I want Mandeep, if you are here, Mandeep, you are mute. Can you unmute yourself?
Yep, I can hear you, Dr. Amri. No.
Yeah, you have any comments? At least keep the mic with you so you can hear me.
I just have to reach a consensus. I want to take opinion from the gentleman that what gauge do you prefer for these myopic macular holes? Do you still go for 25 gauge and use the 25 gauge instruments, or do we go for the larger gauge? Maybe
23 gauge, I think. All we use 23 gauge.
I use a 23 gauge vitrectomy, as I told you.
Exactly. So we did this mistake of actually moving to 25 gauge altogether, and when we attempted these cases, eventually, you know, you had a slot me and go with 23 gauge and grasping forceps and then finish the case. So I think one of the important take-home messages should be that we should go for broader cases for these broader gauges for these cases.
Yeah.
So,
Thank you, Mandeep, for this comment. There is any comment from Dr. Carlos, because there is a question from me to you, Dr. Carlos.
I want to ask you, all of you, I think we all agree that we peel the internal limiting membrane and the perforate carbon liquid. I think we agree with that, right? In retinal detachment and macro hole, because in some meetings, there are some surgeons that say, no, don't do it. Then I think we agree on that, okay?
Agree.
But the second thing is, and let me tell you one of my problems. You know, when I mentioned the tissue over the macular hole, over the retina, this tissue is you know, fluffy tissue. Sometimes you begin to remove this and you have this fluffy tissue over the ILM and you put it over the hole. Then we cannot dissect this fluffy tissue from the internal limiting membrane in some cases. Then what do you think about this? Because, you know, sometimes I put this over the macro hole and say, oh my God, you know, this is not the internal limiting membrane. You have the internal limiting membrane, but this fluffy tissue, this is cortical vitreous or whatever it is, you know, over the macro hole. You try to do something, or, you know, it bothers you? You think about it, or?
Let us take one by one. Dr. Ramzi, what you will do?
Okay, agree. So in some case, as you mentioned, Carlos, we observe such tissue like degenerative type of lamellar macular hole. So in that case, I use this tissue as a patch or the macular hole. I don't remove that. So my question was, the next question was, do you have any experience about the patch technique like amnion membrane or retinal autologous transplant in such difficult case or failed macular hole case? So this is my question. I think Carlos has some experience about this technique, but in this degenerative tissue, Carlos, I try to keep it there and use it as a patch. If I manage to peel the ILM and invert ILM, I keep it under ILM, or if not, I just want to keep it for the macular hole as a patch.
Okay, let us take the other opinion, then we will come to your question to Carlos. Okay, Dr. Ayman, what we will do?
Can I say just, I agree totally. It's atypical membrane as we find in lamellar macular hole. We know you have the typical membrane that's you find it as a sheet of membrane over the whole macula, or sometimes you have this type of atypical membrane that have, as Ramzi said, an edge, and it's really very, very difficult to peel, to remove. And I think if you attempt to remove it, and you can, which is most of the time difficult to do, I would not be persistent to remove it, because it will do more damage to that area. And probably what Ramzi suggested would be the safest way to do it.
Is there any other opinion other than what Dr. Ramzi and Dr. Ayman mentioned, or it is same? So let's go back to you, Dr. Carlos, and the question of Dr. Ramzi.
Yeah, I have experience in total retinal transplant. I have experience in that. And, you know, for me, it's a good experience. But if you ask me, there are two kinds of patients, you know, macular hole with retinal detachment, macular hole without retinal detachment. In macular hole without retinal detachment, my results are not good. You know, they don't improve vision. Then in my cases, I don't know in other doctors, but in my experience, no improvement. But in the cases where you have a big macular hole and retinal detachment is a great thing. And I haven't tried the amniotic membrane. I think it's the same. I think the results are the same, and I don't want to put another thing inside the eye from outside the eye. I don't like it, and I had to grab a peripheral retinal tissue. But at the end, and Ayman said the key point, to maintain the flap inside the hole. And I put it over the retina, not down. And then how you are sure that you have, the tissue inside the hole at the end of the fluid exchange. And Ayman said the key point. And he mentioned that he was using autologous serum as not as a proliferative, magic liquid, as a glue. And the thing I do on the perforate liquid, I have the blood of the patient. I have the platelet-rich plasma from the patient. And then I go there on the perforate liquid with the retinal tissue. I put 2 drops over the hole. I put the retinal tissue there. Believe me, do it in interlimited membrane transplant. It stays there. It never moves. And, total retinal transplant. Do it under perforate liquid and always stays there. Don't forget about the movement of the flap and in the interlimited membrane or the retinal transplant.
Thank you, Carlos.
Let me ask another question. I think you believe that retinal transplant or amnion membrane is not more than a patch. It's just patch.
Yeah, perhaps it's a patch, but if you have a total retinal detachment, again, you have the advantage to close the hole and to maintain the retina touch.
Okay, but is patch to close the hole and to attach the retina, but there's no functional effect.
I fully agree. I fully agree, my friend. Yeah. Because of this, I stopped to do it in no retinal detachment cases.
Yeah. I asked this question because of also not on the map, but also the standard macular hole, also in failed macular hole cases. So we use this technique from time to time, but in my practice, I also observed that, yes, we improve some vision, but it's not because of the retinal transplant tissue, it's because of the attachment of retina around the detached hole. So therefore, I agree with you. These are not more than a patch. They don't give any functional benefits. This is at least my practice experience.
Fully agree. It's only a scaffold. In fact, I've never tried amniotic membrane graft. I once tried part of the lens capsule. I did a vitrectomy, vitrectomy, and I kept the lens capsule, in fact, and there was a large hole and I could not peel the ILM, and I put part of the lens capsule itself over I put the autologous serum, then I put the capsule over the hole, and it worked. I don't know, it worked because of the lens capsule working as a scaffold or for any other reason, but I've done it once. But I've never used the amniotic membrane graft or autologous retinal transplant.
Good. You are muted, Mohammed.
Sorry. Sorry. Thank you, Dr. Nazim. Thank you, Dr. Ayman. There is only one question. I don't know if there is any controversy of using a gas or to use a silicone. Is there any difference between a surgeon about this one or not?
This is also a very important question. As you know, Dr. Muhammad, in cases of high myopic retina, in cases of normal myopic retinal detachment, I prefer to use gas because of all these, deformities that present in the macula, posterior staphyloma. Gas works better, definitely. But in cases of the presence of PVR or a myopic macular hole where you need a prolonged tamponade, I use silicone oil.
Is there any other opinion, or you all agree on that? Dr. Carlos, Ramzi, Nazim?
Yeah, we agree.
Yeah,
I agree, fully agree.
Okay, I think, thank you very much for all these comments. We are having 3 questions or 2 questions. One is this one, I think, for Dr. Mandip. Do you think use of atropine 0.05% eye drop to prevent myopia progression might help to lower the risk of development. No, this one for Dr. Ayman, myopic macular hole.
Well, I know that it has been used in children just to prevent the problem of progressive myopia, but I don't have any idea if this is going to prevent the development of myopic macular hole later on. I don't have any idea, but definitely.
Is anyone here, Dr. Ramzi, Carlos, or Nazim, any comment about this question?
No, I think the whole question is different. Because myopia is used to reduce the progression in childhood, so that is not, it cannot change the progressive or pathologic myopia. It has not worked. The study says it works good when the refractive error, when the child is between 2 and 4 diopter. So that you know, in pathologic myopia,
not in a high myopia, I mean. Okay.
Yeah, progressive pathologic myopia. And I think one more important point, if you will agree, in such kind of high myopia, if you have a macular hole is one factor. If you have multiple holes, I think when the retina settles back, it will be very difficult to identify those holes. Isn't it a good idea to mark these holes with, you know, endodiathermy, so that you don't miss the holes to laser it at the end of the procedure?
Let me just add one thing, just for our junior colleagues. There's a difference between high myopia and pathological myopia. Now, high myopia means any person who has a refraction of more than -6 or has an axial diameter more than 26.5. Now, pathological myopia is different. It's you have all of this added to that, these pathological changes that's happening in the choroid, retina, and the sclera. Now, you have all these pathological changes, this is pathological myopia. And I don't think at this stage, if you use anything, this is going to stop the pathology from progressing and developing.
Nazim, your question is very important. During the working on the macular area on the staphyloma cases, sometimes we may create holes around the vessels or the other area. But we can see these holes during this action. But then, if we leave that, we cannot find later on. So you mentioned about that point. So it's really a good idea to mark this area with tiny diathermy and to do laser later on. Except foveal macular hole, we can do this. I do it in my practice, not only in macular patients, also in regular retinal detachment case during vitreous base dissection. If I see create a small hole or some thin retinal area, I mark with endodiathermy and then do laser only the selective area, not 360 degree.
Yeah, also in albinotic fundi.
Yeah, exactly.
Okay, thank you. Yes, Dr.
Yeah. Let me ask you one more difficult case. You have a total, this is very difficult. You have a total retinal detachment, a high myo with posterior staphyloma. You don't have a macular hole. How you find, or how you try to find where is the hole? Where is the break? Is posterior break or is anterior break? How you proceed to find the break? How is your steps to
let us have your answer before.
Well, the thing I do is first I put perfluorocarbon liquid. I go to the periphery. If the retina makes ballooning, it means that there is no peripheral break. And I remove it and I go down and I try to see around the optic nerve, around the vessels, or in the white areas of atrophy. These are the 3 places where the holes, posterior holes are. But I first check with perfluorocarbon liquid. There is no fluid going away. Then the break is posterior.
Is there any other opinion?
What I will do in case if there's I cannot see a hole, I usually use a strong light and I indent at the periphery. I indent every part of the periphery and I use my light, shiny light on the retina. And in most of the cases, if there is a peripheral hole, even if it is small, you will find it by using the indentation. Now, as Carlos said, if you cannot find anything in the periphery, you have to look at your posterior pool. You have to look at the pathological area for small holes, and you have a tiny macular hole at that time.
Okay,
And
Dr.
I think
Ramzi?
Dr. Dr. Khalid Sapti used subretinal dye to visualize a hole. I don't know if it's toxic or not, but I think they use tryptophan blue to give subretinally and identify the posterior or peripheral retinal break. I did not try, but this is another idea. But I agree with Carlos. If when we put perfluorocarbon, if the peripheral retina is like bolus and there is no leakage, there is no passage, so this is mean that the tear is on the posterior fold.
Thank you very much. There is only the last question. This one, I think it will be for Dr. Mandip. When you said naive eyes for vitrectomy, do you mean before IVI laser, or if so, how do you choose the case?
Yes. Yeah, I think there are two parts of it. First thing is what literature shows us, naive means patients who have never been treated with any other modality, and vitrectomy as first line of management. What I did in my 3 cases, we used vitrectomy as first line of management in 6 patients, 3 knives. The 2 patients had extramacular tractions, which were detected on OCT. And there was 1 patient who did not have it. So it was a patient who did not have any traction, but I had to do it for monetary reasons. I don't recommend it to be done. Obviously, in such patients, you would inject anti-VEGFs first, and really there is I don't know the answer. How many anti-VEGFs should you inject before you choose to go ahead with vitrectomy? I can't answer that because it's not been answered in the literature itself. So yeah, I did 1 patient which had absolutely non-tractional naive DM.
Mohammed, let me ask you a question, Dr. Mandip. In diabetic macular edema cases, what's your schedule? First, you try you use anti-VEGF in a non-tractional case I mentioned, and then the second choice is vitrectomy for you, or what about the steroids in some chronic case that you mentioned in your case, and you apply anti-VEGF, then went directly to vitrectomy? What about steroids in your practice? Do you use steroids in this patient?
No, we don't use vitrectomy as for up to very late cases, to be very frank with you. We do use anti-VEGFs first and then do switch to steroids, and I mean like all of us do. And the whole point of this discussion was actually, can we implement vitrectomy early? I don't do that. I was forced to do it, but I don't recommend it to be done because there's no evidence in favor of it. There are discrete evidences, but the topic is up for discussion. We don't have any large sample size RCTs telling us how we should implement vitrectomy in DMEs early on.
So any of you believe that early vitrectomy works in diabetic macular edema in naive cases, and any of you believe that? So in my practice, I don't think that it works, and in a naive case,
I don't.
First choice.
Yeah, I think once you do with anti-VEGF, you are given multiple injection and it is not responding, and you do see on your topographic map of your OCT some elevation which you saw actually is very good. You can do a topographic guided laser. But however, I will say I will revisit that case. Revisiting means I will do a dynamic fluorescent angiography to understand the leakage pattern and what your topographic mapping is showing on the OCT. And if now that we have got a good OCT, you can interface study is pretty good. And if you think your perimacular area doesn't have any kind of changes, interface changes, then probably treating with lasers will not increase the thickening of the posterior cortical vitreous interface with the retina, okay, in the posterior pole. Then I think we will go in that. So I think that will be my next step. And if I don't see anything and there is still an edema, then I would go for intravitreal steroid, as Dr. Ramzi has said. And if it is still not, I will be a little bit hesitant because previously we used to do vitrectomy for non-resolving diabetic macular edema, even with subretinal, with hard exudates. The results were, we burnt our fingers. So so I would put it, unless I see and do a good OCT with the present technology, seeing anything evident, or even if you do an NFAS, when you do an OCT angiography, you see the NFAS image. Sometimes you will be able to see the ILM, even slightest of the wrinkling,
Yes.
Yeah.
Exactly.
Then you have an excuse. You have an excuse. Okay, I will go inside now because I tried anti-VEGF, I did the laser, I did the steroid. So I might as well go in and remove the ILM. That may also improve the oxygenation after removing the cortical vitreous, and you may even consider to give anti-VEGF.
Thank you.
Thank you, Dr. Nazim. I think we are already exceeding the time. If you continue, we'll not finish even within 1 hour, I know.
Okay.
So I have only the last comment from Dr. Tariq, I think. Okay, within few seconds, please.
Thank you. Yeah, Mandeep, just a quick question. I mean, the consensus to try vitrectomy, I think you need to try 3, or people say some up to 6 injections before you say this is refractory diabetic macular edema. So what's the rationale makes you to go for vitrectomy? I mean, if it's non-tractional diabetic macular edema, I mean, how do you know that this patient?
He explained this one, I think, Mandeep, right? Before.
Yeah, we do interface study. If there is any anomalous traction onto the macular surface, then we might think about early vitrectomy. Now, I'm not recommending vitrectomy for naive patients, and I'm again saying that I did it for monetary reasons, I don't recommend that, all right? But we have to have a discussion whether are we delaying the vitrectomies too long before we try all kinds of switches and then move to vitrectomy. Then we do vitrectomy much later after 2 years and say, no, it doesn't give good visual acuity returns. Because by the time ELM is gone and EZ is gone.
Well, I mean, vitrectomy can help if you have a taut posterior hyaloid, with ILM peeling.
Well,
I think we can keep the discussion for the next time, maybe, if you allow me.
I'll talk to you.
So many.
We will have a phone call on this.
Time is, I'm sorry to interrupt, but I'd like to thank you all. It was a very nice and interesting discussions, and we will go on same like this one. So next week we will have anterior segment, and after that we'll have the posterior segment on 16. So thank you for all. Thanks, Dr. Ayman. Thanks, Dr. Tariq, Dr. Mandeep. Thank you, Ramzi and Carlos and Nazimul. Thanks for Bayer for sponsoring this meeting and also for the management event. And thanks for all our attendees. Waiting to see you, inshallah, next week. And good night.
Thank you, everyone.
Bye, guys. Great, Ayman. Great done. Perfect. Perfect. Thank you, guys.
Your opinion was highly appreciated. Thank you.
Oh, perfect. Thank you, Mohammed, the boss.
Thank you,
boss, the boss of the world. You know. This is the boss.
Really good job, Mohammed. Really good job.
Thank you very much. With your presence, we will do nothing. Thanks a lot for being with us. Really appreciate that. Thank you.
Bye.
Thank you.
Bye.
See you. Bye-bye.
Thank you. Good evening, Carlos.
Bye.